Bismillah ar-Rahman ar-Rahim, my dear vascular colleague, another lecture on vascular golden card. This time we're going to speak about the new guideline from the European Society of Vascular Surgery on the aorta that has been launched in January 2024. If you want a picture of the slides, you can just have the photo of this QR code. You will get an access to the card right away. I will try to summarize what is the difference compared to the previous guidelines. So the new guideline is freely available over the internet, and it is the European Society of Vascular Surgery guidelines. And this, it took around 2 years for European Society to issue this new guideline. The one before that was done by the cardiology, by the American American College of Cardiology and American Heart Association. It was 2022. It's very beautiful guidelines, recommended to read it, and then we will see the difference that has happened between the European Society Vascular Guideline and the American College of Cardiology. By the way, in the ACC/AHA guideline, there was a surgery, there was vascular surgery on board. So it was not by cardiologist guidelines. There was surgeons in the committee. Now, if you divide the guideline, it's about 140 pages, and you can easily read them in a couple of hours. I've tried to summarize the important element about epidemiology diagnosis, which is the first section, then a small AAA, elective AAA, management of rupture AAA, follow-up, complex AAA, iliac, miscellaneous. I will concentrate on what is new and what you can learn from it. I usually like to put it in one page. I call it one pager. And this is the first section, which is epidemiology, diagnosis, and screening. Now, one of the very important recommendation that has it changed, it was not before. If a patient with asymptomatic abdominal AAA who has reached size threshold, which is 5.5 in males and 5.0 in females, if you reach that size, you should go on fast track pathway. What is fast track pathway? Because not every country have this. If you are a vascular consultant and you have a waiting list for aortic aneurysm repair, and you get an asymptomatic patient and the threshold of size, and he has risk factor to add to that, then you should give what is called 8-week pathway. If you're unable to give him operation time by 8 weeks, then the health authority will appoint another consultant. So this has been changed. It was not in the past, and this for high risk group. Now, the second important point, we know that when we measure the abdominal aorta on ultrasound, you have three diameters. You have inner to inner, which you measure from inside the aorta, or you have outer to outer, where you measure outside the aorta, or you have what is called leading edge to leading edge, which is something in between. In United Kingdom, they use outer to outer, while in Sweden they use leading edge. In some other centers they use inner. So this this guidelines showed that we better rely on the outer to outer and AP diameter, which is this diameter of the aorta. So there was a lot of debate. If you have an aortic aneurysm where your maximum diameter is the transverse diameter, what do you should do? Do you consider this a 6 centimeter aneurysm, or you take the AP diameter, or you take the maximum diameter, even if it's trigeminal? Now, from paper-wise, in order to standardize things, we will rely on the AP diameter. So this is the recommendation which has changed. It was not in the past. The AP diameter with consistent caliber placement should be considered as the preferred method for ultrasound abdominal diameter. And we hope that this will become standardized. Evidence is level of evidence B, and grade of recommendation, class of recommendation is 2A. So this is important. Secondly, we know that the aortic aneurysm in systole is smaller, in diastole it is bigger. Which one do you measure? So now there is a technology which is called electrocardiogram gated ultrasound and CT scan. It gives you the average between the contraction during systole and relaxation during diastole. So it gives the average between systole and diastole. It's called electrocardiac gated ultrasound and CT scan, the same technology. If you want to do surveillance, then you better rely on ultrasound because it's cheaper, easy, straightforward, and you don't have irradiation. But if you want to treat, CT scan is mandatory with 1 millimeter cut section. And this is the requirement for you to diagnose and manage aortic aneurysm. Now, in this section as well came recommendation number 9, which computerized tomography, computerized CT angiogram is recommended for treatment planning once anteposterior diameter threshold for elective aortic aneurysm has been met by ultrasound for diagnosis of rupture. This is a class of evidence 1, level of evidence C. So it's a recommendation from higher authority. So the AP diameter is the standard of care. Now, aortic diameter measurement with CT angiogram is recommended using dedicated post-procedure software, as you said, cardiac gated, consistent caliber placement in orthogonal plane perpendicular to the aorta. So you measure, if this is aorta, you measure the AP view, and this is where you lie your judgment. And we'll say in the next section, it will be 5.5 centimeters in males and 5.0 centimeter in females. Now, recommendation number 11, there was a lot of debate regarding screening. Does screening detect enough cases? They said if you have done around 1,000 screening, you probably will save one patient from having rupture before treatment. So this maybe is not a cost-effective way of managing, but there was 2 countries, United Kingdom and Sweden, which have shown that in UK and Sweden, the survey did save life and did save cost as well. So recommendation number 11, ultrasound screening for early detection of abdominal aortic aneurysm is recommended in high-risk population. So not all population, but if you take diabetic patient, hypertensive patient, and if you take a smoker, and let us say above age of 60, this is considered as high-risk population, and it is recommended to do screening. And this will reduce death of the aneurysm rupture according to United Kingdom and Sweden. So I hope we have now summarized the first section of epidemiology. It's important for the exam. They get you ultrasound picture, how you can measure the diameter, which diameter do you take from the aorta, and they will ask you about the screening. It's also a very important topic for the exam for the European Board of Vascular Surgery. And if you just go to the QR code, you will get a summary of this first section, number 3, and we'll go to section by section to have easily digest this new document. And, and I hope with this quick summary, you have been able in 10 minutes to grasp around 10 pages of the first part of ESVS 2024. I wish you all the best.